Hi everybody, I'm Laurie Cadden, and we are here at the beautiful TCMC having a great conversation. I have to say it all the time, they're two doctors, but they're also very handsome, right here to my left. Very happy to be here. We're here to talk about once again, for our third segment of the Public Health Education series. We're doing 12 of these, you lucky people getting to watch these wonderful docs tell you a little bit about how you can be in better health, how you can take better care of yourself, and just in general, some basic information to make you a little bit smarter about the world of health. So we're here today to talk about cancer screening. And we have two guys, blue-eyed guys with us. We have down at my far right, we have Dr. Greg with two G's, Severs, and he is with the Lackawanna Valley Dermatology Associates.
That's right.
How long has that been called that? Not
well
that long,
I
is
was
it really?
there. I mean, I think probably since the early 80s.
Okay,
probably.
because I'm trying to remember. I told you with Dr. Zanker.
Yeah, well, initially it was Dr. Zanker and Sheldon.
Yeah.
He founded the group, and then we grew from there.
And here you are today.
Yeah.
There you go. Well, thank you for joining us.
Thank you for having me.
He's a dermatologist and happy to be here because we're going to talk to you a lot about how you can check and be checked for skin cancer, which is so important and I believe very overlooked in the way we go about having ourselves checked and the health of our skin. Sometimes we look at our face only, right, doctor? So
True.
It's very important to understand why you would get cancer of the skin. And John and I were talking about being so Irish that we should be there, as he said, every other day or every day to be checked. So we also have Dr. John Farrell. He is with Radiological Consultants. John is a radiologist, and he and I have had plenty of practice with this because many times before, ECTV has done great work with these type of educational series at Advanced Imaging. So John, you're a pro at this. Greg was a little nervous, but I think he's okay now after listening to the pro here.
He will be fine. Yes.
He'll be fine.
Thank you.
So let's start out by saying, what is cancer screening? What's the difference between having diagnostic testing and preventative? Where does it lie? I don't care which one of you jump in first, but how do you tell people what that actually means?
Well, to screen for any type of cancer, we are speaking of early detection, whether we're talking about breast cancer, skin cancer, lung cancer, colon cancer, cervical cancer, prostate cancer. When we screen a patient, there's the assumption that the patient is asymptomatic, meaning that the patient has no symptoms, the patient is feeling fine and in a good state of health. Though could a particular patient who is feeling fine have an early cancer? The answer, of course, is yes. So the idea is that we're screening patients who are asymptomatic for possibly early cancer that could hopefully be cured or at least treated so that it has minimal impact on the patient's quality of life. A question that I'm often asked, and Greg has probably asked it too, is when are we going to find a cure for cancer in general? And that's a hard question to answer. And right now, the best answer we have is early detection. Mm-hmm. And that is our cure currently. And so that's why there is such a emphasis in the U.S. today and around the world on cancer prevention and early detection of cancer through screening tests.
And can I still say, please, because this warrants a constant in your face, this is what you need to do. Stop smoking. I mean, we talk about that all the time. When Dr. Stallman was on, he used to say, two best things you can do for yourself, two things: wear a seatbelt and don't smoke. And I always hear, when I click my seatbelt, I hear his voice in my head from having done this show. But really, that ages the skin. It also causes so many issues. I know it's a terrible thing to try to quit, but really, isn't that one of the most simple, if you can call it simple, because I know it's addictive and I know it's so hard to do it, but isn't that one of the easiest things in many ways to be able to do?
Sure. Someone who smokes regularly or has a history of smoking, to be able to stop and to quit and to stay quit is going to improve your health, your well-being, and your longevity, in many ways, not only with respect to cancer prevention, but as you suggested, in every other way, it's just making you feel better on a day-to-day basis, decreasing your chances for cardiovascular disease and stroke, and yes, so the health benefits are many.
And in your case too, Greg, what it does to the skin is even your face. I'm talking the skin on your face.
Sure. I think there's like John was saying, there's very few types of cancer in general too that have such a well-defined risk factor as smoking and lung cancer does. I guess it always comes back to the skin for me, but same with sun and skin cancer. Basically, that's one risk factor that you can easily, you would think, modify to change. Quit smoking. Protect yourself from sun. I mean, to me, those are two very well-defined. Other cancers have multiple factors that, variables that factor into whether or not you would develop those cancers, but I think those are very well-defined things that you can easily change and really change your life, really.
So if you're going in and you're saying you're asymptomatic, which means you don't have symptoms, you're going in for regular checkups to have these tests done. Is that just something that people should do yearly, depending on your age and the risks that you have, or is do some people just they go through and they don't have? Like, what is the recommendation, and how would you go about that? Even from you as well, Dr. Severs. We said earlier, what do? Well, you can have your face checked, you can have a whole body check. What's important on both of those?
Well, I think it's important to see your doctor yearly. There's been some controversy, especially lately, about do you need a physical every year? Do you need blood work every year? And that may be up for debate, but personally, I think an annual visit, if you're an adult patient and even pediatric patients, but we're primarily focusing on adult patients tonight, that you visit your doctor for at least once a year. You're going to get a physical during that visit, but it also enables that conversation where your doctor can sit down with you and say, okay, this is how old you are, these are your risks, and you can determine at that time what screening tests you need currently, what screening tests you will need for the future, what screening tests are you overdue for, should you have had already. So that's why I think that regular visit to your family doctor, your internal medicine doctor, your family medicine doctor is important, and even your obstetrician gynecologist, to have that annual conversation to make sure that anything that's preventative can be taken care of.
Yeah, I agree completely. I think every different type of cancer has its own set of guidelines and screening, but basically you need someone that's going to coordinate that, and that's typically the family doctor or internal medicine doctor. Whether you fall into a certain age group or you have certain other risk factors, whether it's family history or personal history of certain exposures and things like that, that might guide your primary doctor as to how they might screen you for different types of cancers. And again, screening we're talking about before symptoms, hopefully, but also certain tests might be ordered based on symptoms you may be having as well.
Now, when different types of screening, and we look at certain modalities for certain cancers, are there other ways that we would commonly say, okay, for colon cancer, it's a colonoscopy? Now, I know, thinking of what you have to do for that ahead of time, and that's what most people say, it's the prep that's the worst part versus the actual test itself. Sure. So are there other types of, I know there's what's it called, a sigmoidoscopy, is that the correct term? Instead of a colonoscopy, which doesn't go through the whole colon, I think. What are other ways, other types that can be used if someone is afraid or wants to go a little bit less in the testing? Are there those? Do you recommend that? Or is it really just the tried and true on the testing?
Yeah, I think with a lot of things, there's the gold standard test, but then, if patients, come back to skin, for us, we like to say you should have a full body skin exam to look at all your spots or, moles or growths or whatever. But, some people say, they're either embarrassed or, certain, standards, they just don't want to have, certain areas checked, and that's okay. I think, getting some areas checked is better than having no areas checked. So I think you can kind of correlate that to, I guess, colonoscopy and sigmoidoscopy. You're not seeing the whole colon, but at least you're seeing part of the colon, and maybe you would detect something potentially there. But understand that you're going to possibly miss something as well if those other areas aren't checked. And I'm sure there's others, from other types of cancers that I'm not thinking of. But I know from a skin cancer point of view, we leave it up to the patient. We say basically, we can check your entire body, or you can leave different parts of clothing on that you want to keep covered, and we'll look at the other areas, basically.
The biggest barrier to screening in general is fear.
Right.
Fear associated with the test.
Fear, or do you not think what the result will be?
Exactly.
I was going to ask that. Do you think more people shy away from the test because they don't want to know the result, they're afraid to find out, or because they don't want the test, or a combination of the two?
I think it's a combination of both. They don't want to know if it's, they don't want to wake that sleeping dog. But I think, that there's a lot of fear. The fear of the prep for colon cancer screening, colonoscopy, that's probably the biggest barrier to getting screened for colon cancer. People, they hear everyone has a bad story about a colonoscopy prep, but the truth is that the prep has been tweaked. It's been modified over the years. It used to be a 2-day prep, and now it's down to 1 day, and it's become a lot more tolerable. You still have to do it, and doing it and complying with the directions ensures that you'll have a good colonoscopy, that the prep will be good enough that they'll be able to see your colon well. But the truth of the matter is, most patients that I speak to who have colonoscopies, they say, well, gee, the prep wasn't as bad as I thought it would be. And it goes the same for other screening tests. For mammograms, there's concern about pain when the breasts are compressed during a mammogram. The pictures are very quick for a mammogram, and yes, there's some temporary discomfort. I know that being a man, it's easy for me to say that.
Yes, it is.
But the information that you get from that momentary discomfort is very valuable, very valuable.
And that I can say, I can attest to this. It is definitely very fast. So, you're holding your breath anyway, so sometimes when you hold your breath, you can't feel anything. So just do it and move on. But yeah, I mean, that makes sense. But I do think that people, there's always that hanging over your head, that fear of the unknown. I mean, I know I'm not more afraid of the test as much as I worry about the outcome. That's where my fear goes. So I think we all have a little bit of one or the other.
Absolutely,
Sure.
absolutely.
Yeah.
Do you guys as doctors have those fears, or it doesn't even faze you?
I do.
Do you?
Yeah.
I think everybody, doctors are humans like
I
everybody.
know, but that's
so
my point. I always
sometimes
say
it's worse, I think, because you have
You know
some
too
knowledge
much,
about some things, and you start to. It's like I think when you're in medical school, you go back to, you start learning about some of these things. You think you have everything in the beginning, and then as you go through it, you realize you don't. But I think when you start to, as a doctor, the worst case scenario. So when you hear little things, you immediately think that. Most of the time, it's obviously not that, but so it may be even worse. But yeah, I think we have the same fears that everybody else does. But also, I think we know it's a necessary evil, and we know the benefits of it as well. So.
Now, are most cancers hereditary? Let's even talk about skin cancer. Is that hereditary? I don't hear that much. I know other types, breast cancer, colon cancer, different things. If it's familial, that's an issue. Is skin cancer something?
Yeah, so there's definitely some genetics to skin cancer. The most common types, basal cell and squamous cell. Probably the primary issue with that type of cancer is more the genetic skin type. So people that are fair-skinned are at higher risk, and not so much as like a genetic mutation, although there are with basal cell, especially certain gene mutations in people that have certain syndromes. But in general, the common basal cell and squamous cell skin cancers that we see every day, those are more related to just being fair-skinned most of the time and sun exposure over the years, and maybe not even being fair-skinned. People that have significant sun, work outdoors, go to tanning salons, have a lot of really high-risk behaviors from a sun or ultraviolet exposure. Those are high-risk people. But melanoma, I think, is the one that has the strongest genetic influence to it, and there's definitely some strong genetics with melanoma, because melanoma can truthfully develop anywhere on your body. It can develop in sun-protected sites, genital area, the bottom of the feet, between your toes, strange areas that you don't think obviously aren't getting a lot of sun. And that's why when we do recommend the full screening, it's because of those risks, because we do occasionally, see melanoma in those areas. Even squamous cell can occasionally be out of sun-exposed areas, and so, we do like to do the full body check, but still we respect people's boundaries in that regard as well. But from a genetic standpoint, melanoma is the one we really worry about. If you have a first-degree relative with melanoma, that certainly significantly increases your risk to develop a melanoma at some point. So those are people, when you have a first-degree relative with melanoma, we always want to do at least a baseline screening. So when we have a new patient with a melanoma, we say, you might want to talk to your first-degree relatives to come in for a screening just to get a baseline exam. And then if they don't really have that many spots, you kind of teach them and maybe come in every so often. But people that have, a lot of moles and a family history of skin cancer, at least a yearly skin exam is a good idea, especially if they themselves have ever had a melanoma or atypical moles or anything like that. And same goes with the other types of skin cancer. We start, getting a lot of people into this routine of yearly exams once they've had one or two of these skin cancers. And we have patients literally that have, 50 to 100 skin cancers throughout their life. So it's incredibly common.
And so therefore then anybody with the family history of cancer, I guess the screening should be, and I know that some with cervical or breast, they bump it up like a good 10 years. Is that still true, or is that getting lessened a little bit these
No, that's
days?
so with breast cancer particularly, there's a strong genetic component, especially the mutations that are most commonly talked about are the BRCA1 and BRCA2. Those patients have a much higher risk of developing breast cancer. And so screening for those patients is accelerated and more aggressive. But in general, the American Cancer Society's current recommendations are that for average risk women who don't have a primary relative with breast cancer, that screening begins with mammography, an annual mammogram, at age 40. Okay. However, if a patient's mother was diagnosed with breast cancer at, say, age 38, you don't wait until that patient is 40 to start screening them. We typically start screening for breast cancer 10 years before the primary relative was diagnosed. So if the mom was diagnosed at age 38 or a sister was diagnosed at age 38, then that patient would start getting annual mammograms starting at age 28. So giving us 10 years to say, well, gee, if this patient were to develop a cancer at a similar age, hopefully we can detect it even sooner. So another reason why the discussion, the annual visit to your family doctor is important, because your risk factors and your genetics is kind of a moving target. You may come into your doctor today and say, I have no family history of breast cancer, and that's fine, okay. But when you go a year from now, you could say, well, gee, in the past year, my mother was diagnosed with breast cancer, my uncle was diagnosed with colon cancer, you could have significant changes in your family history that could impact your own screening and your own preventative healthcare testing. So that's why, again, it's not a static moment in time, but you need to have that discussion, that dialogue with your family doctor, so that he or she can be abreast of your risk factors and your histories and family histories.
And then if someone has to have the test or recommended that a test be done earlier, what are the insurance ramifications and coverage issues there? Do they cover based on that? How does that work?
Typically, yes. Once you prove to the insurance company that you are high risk, okay, and there's several ways to do that through genetic testing and other tests. The writing is on the wall. It's pretty black and white. The insurance company, in almost all cases, will go ahead and cover accelerated and early screening in those patients. For your average risk patients that we talked about earlier, like the average risk woman who gets a mammogram every year, most insurance plans, including Medicare, would cover basic screening. Sometimes they are a little bit picky about if you had your mammogram on August 30th and the next year you showed up on August 15th, they'll say, well, it has to be August 30th. But even most of the plans now will say we'll cover one screening mammogram every calendar year. Okay. So they've relaxed that a little bit.
Which should be, because some people like to do it right on their birthday or right the day before. It's a way of doing it.
Absolutely. But a question that I'm also asked often is, but if I need more than one mammogram a year, if something is getting followed up, or if I develop a lump in my breast 6 months after my screening mammogram, or I have pain in my breast 6 months after my screening mammograms, Can I get a mammogram? Will my insurance company pay for it? The answer is yes, in most cases, because at that point, you're not getting a screening exam, you're getting a diagnostic exam, because you're presenting to us with a symptom or a sign.
Right.
I have a pain, I have a palpable lump. So that's a different set of tests. That's a diagnostic test that is considered separately from your mammogram. We, of course, will compare to your screening mammograms when we read the exam, but it's under a different set of exams and therefore is not considered screening at that point.
And that's sort of, I jumped off of that at the first question, that is the difference between diagnostic and screening. Screening is asymptomatic, and diagnostic would be the possible, a symptom or the thought of that, correct?
Right.
And then, okay. And then, Greg, on your end with testing and insurance coverage of going, how does that work for regular skin care checks with the dermatologist?
Yeah, it's usually not a huge issue unless someone has a very strict plan in that regard. Some people are only allowed a certain number of office visits per year. But in general, we don't have a lot of trouble. Again, and how often we're seeing someone is all based on their risk as well, whether they have a history of skin cancer, or other things we look at as far as assessing how often someone needs to come in is their sun exposure history, their skin type to some degree, their family history, personal history. But in regards to like having someone come in more often than once a year, I often have patients that have multiple precancerous lesions that we see them basically every 6 months in hopes to prevent them from having the chance to turn into skin cancers, because the treatment is significantly different. Precancerous lesions that we're able to treat on your routine office visit by either cryosurgery, by freezing them, or other ways. There's topical medicines that we sometimes are able to use as well as other treatments. Before, the cost to the insurance company is significantly less if we treat them as precancers versus skin cancers, where they would have to be excised and other things done more surgical that are more costly. So the insurance, I guess, for some reason, doesn't really give us a lot of trouble as far as seeing some people more often, because I think it's preventative to some degree, that they're going to prevent skin cancers and hopefully save money in the long run, and again save hopefully lives as well by catching things earlier.
What I don't understand either is there's so many things with blood work, and I know you guys aren't pathologists or in that realm, but blood work is so important for so many things. Why can't blood work determine cancer? And I know it does in some cases. So why isn't blood work good enough?
Hopefully someday we'll have a comprehensive blood test that will enable us to screen for many cancers and many genetic mutations with a simple vial of blood. And as you alluded to, it is helpful, though controversial for some cancers. Prostate cancer is the first cancer that comes to mind. The PSA is a controversial, we don't have a urologist here unfortunately, but it's a controversial test for the detection of prostate cancer. It's a commonly used test, but the recommendations, the formal recommendations by the American Cancer Society right now are a little bit vague in that they're not necessarily recommending that men get it every year, because there are a lot of false positives, there are false negatives. So the answer to the question is that it would be great if we had more cancers that could be screened with a simple blood test. There are tumor markers that are used for patients who have known cancers, that for specific cancers they can test for certain markers to detect if the cancer has recurred or not. But even those tests are not foolproof.
Right.
There could be false positives, meaning that the test is positive but there's no cancer. There could also be false negatives, meaning that the test is negative but the patient does have cancer. So there's no true perfect screening test, whether it be a blood test or imaging or physical examination or endoscopy. There's no true perfect screening test, though we do have very good screening tests.
So do you think that blood work has more of the false negative, false positive than the other types of testing that go along with it? It seems to me that happens more than the other, or isn't it? Is that pretty too general of statement?
Well, no, you are correct in that you could have a value for any test, anything that you test for that's a little bit off, a little bit low or a little bit high, and that always leaves us with questions. It's like, well, it's probably okay because there's error in the instruments that used to measure these factors, but whenever we see the test is a little abnormal, or for whether it's high or low, that makes us think and makes our doctors think, well, gee, is this a false positive?
Right.
Is it, or do we have to worry about something? And one of the arguments to not get regular blood work is that it causes too many false positives. It ends up causing anxiety, and it ends up causing workups that may lead to nothing. But of course, the flip side of that is, but it could detect possibly something early. For instance, if you're anemic, if your hemoglobin, your blood count is low, that could be a sign of cancer. It could be a sign of colon cancer, but it could also be a sign of many other things. So for every argument, there's a counter argument that says, well, a simple blood test could be a lifesaver as well.
And isn't it true too that some of the way they test blood in the different, however the way that they're different, when I had my recent blood work done, I said, what does this mean? And they said, it's how it was tested. So I didn't realize that there were other ways to test blood, or there were different, I don't know the proper term, but that...
Sometimes there's just variations from lab to lab.
That's what I mean,
as
just
far
the
as
lab
things
testing
being
was so,
elevated
yeah,
sure.
okay.
Absolutely, yeah.
Okay.
Absolutely.
Yeah, and I think too, a lot of, some cancers, there's no blood test for because we think, they're localized just to that organ system, for instance, the skin, or to, the kidney or whatever. And maybe, if, and this is, I guess, archaic thinking, you think if it's just localized there, there's no systemic thing you could test for. But there probably is. I mean, because our immune system is always involved with cancer, so that even for cancer of the skin, although it's not a circulating type of cancer through your bloodstream or anything like that, your immune system probably is aware of it being there. It's trying to fight it off. It's trying to make it go away without you even doing anything to treat it. So there probably is some immune response going on throughout your body. We just don't know how to test for it yet. But as John said, I think someday we will have screening tests for a lot of these things that we don't have tests for now. Even, certain localized types of cancers before they're a systemic type of cancer or metastatic type of cancer.
And even something like ovarian cancer,
Sure.
where there is no testing. I mean, there's that blood work, which is sort of out there. I mean, so there is not available today testing for every form of cancer, correct?
That is true. Yes, yes.
And that
Unfortunately.
being one that really
Yeah.
needs to, I mean, there's ways you could look at it other ways,
Sure,
such as
sure.
an ultrasound, or other ways that maybe that should be something that's automatically done to test, because that is such a silent killer in women.
Absolutely, but all the more reason why we should
See your doctor.
See your doctor and endorse the screening tests that we have that we know are good. Again, not perfect, but good. Colonoscopy, mammography, pap smears, skin checks. Yes, there are many cancers that we can't adequately screen for, but the truth is that many of the common cancers and common things happen commonly. Many of the common cancers we can screen for very well, so we should embrace the ones that we have.
And do we see any decline in people locally being treated for cancer these days? Has anything worked that we see things less happening in the realm of certain cancers?
Well, I think that's a big question.
I know.
It's a complex question,
Yes, it is.
and I'm going to
give
let
us a-
Greg answer that.
One thing
All right,
Well,
just let's do that. And it's skin cancer.
I could
the
focus
fact that
on
we
skin
don't
in that
have,
regard.
well, we have such, our climate is gloomy most
Sure.
of the time.
Yeah.
So do you see the difference? Do you feel more people are caring for their skin with SPH, FP, what is it called?
SPF, yeah.
SPF. It's all these new ones I'm
Yeah.
making up here, but all these acronyms. But what
Sure.
do you think? Do you believe that or not?
I think if you look at statistics, you'll see that the incidence of skin cancer is actually on the rise. But I think probably the reason for that is increased amount of screening. So I think we're seeing, more and more screening. Half of my job essentially is screening for skin cancer. The other portions would be treating skin cancer and then other dermatologic conditions, rashes, acne, and whatever. But at least half of my job every day is doing just body exams on people to screen whether they have a history or they have family history or they're just coming for the first time. So I think we're seeing more skin cancer, but I think we're also catching it earlier. It's being treated a lot earlier, which is decreasing the mortality rate from skin cancer. I think even melanoma, the incidence rate is skyrocketing, but the mortality rate is dropping. So
Okay.
we're seeing more, but we're catching them earlier, and we're treating them earlier, and they're successfully treating them earlier. So, because that's the big thing, I think, again, I'm focusing only on skin cancer, but, if you catch it early, it's very easy to treat. If you catch it late, especially melanoma, it can be very difficult, if not impossible, to treat sometimes.
Okay.
The epidemiology of cancer, and I know what the suggestion is, or there's the question is always asked, why are there so many cancers? And in particular, in Northeastern Pennsylvania, it seems like there's more cancer than there is everywhere else. And the truth is that and it would be great to have an expert on that
Yes.
here, but there's a lot of cancer everywhere. Is Northeastern Pennsylvania unique to the number of cancer cases that we have? Not necessarily. There's a lot of cancer everywhere, and the cause, the etiology of those cancers are many and varied, and we certainly are only beginning to understand in a big picture sort of way what causes cancer. But the most important things that we can do, as you mentioned earlier, are lifestyle modifications. If you are really interested in preventing cancer, will it guarantee that you don't get cancer? No, of course not. But
it
there
helps.
are a number of things that you can do on a daily basis, that anybody can do on a daily basis, that will significantly decrease your chances of developing cancer and other diseases like diabetes and hypertension and cardiovascular disease. And those changes are simple. They're related to our diets, they're related to exercise, they're related to smoking, sun exposure. There's a number of steps that we can take that anybody can take to do that.
Okay. Anything else you'd like to say for the good of the order, Dr. Severs?
No, I think the most important take-home would be, follow up with your primary care physician, get the necessary screening tests that are applicable for you based on your risk factors, and do the things, as John had mentioned, that are preventative, when it comes to cancer and really health in general. We can all do better as far as our diet and exercise and things like that go to significantly reduce our risk of, not only cancer, but heart disease and diabetes and other, very important factors. And I think that's the take-home message today.
You and I and Greg can't go to someone's house and knock on their door and take them to a screening test. That's the patient has to do that.
I know.
And that's often the hardest thing. I always tell patients the hardest thing for you is to show up at my door. Once you're at my door, then it's my job and the job of my team and Greg's job and his team to get you through your test safely, efficiently, professionally, but you have to show up. And if you can get to the door, then we'll take care of it from there.
Well, and that I want to touch on one thing too. You said, Greg, you said we're humans, and I always like people to understand in doing these shows that I think what they do is they show people that doctors are just that. It humanizes you. You become just like everybody else. You just happen to be a doctor, and I think people lose. They get nervous. Just let's calm down and talk to your doctor, and know just from an example of both of these young guys here that. They're approachable and they want to help and they want you to be in good health. So thank you for joining us today.
Thank you.
And again, I'd like to thank Dr. Greg with 2 G's, Severs, who is with Lackawanna Valley Dermatology Associates, and Dr. John Farrell. Please say hello to your mother. I love her dearly. His mother is one beautiful lady. And he's with Radiological Consultants. And next month we're having Understanding Arthritis. How about that one? Do you think you guys could have talked a little bit about that or no? Let me ask this. Are you feeling any arthritis pains these days? You're too young for
Thankfully, no.
Okay. It creeps up on you real quick, let me tell you. And then next month, we're going to have Dr. Chad Walker and Dr. Jeffrey Gillette telling you a little bit more about how you can better understand arthritis. And we'll have, I think, lots of ears on that one since people really want to know what to do, because that's,
Absolutely.
I remember when I was young, my grandmother saying, this hurts and that, and her knuckles would be, and I would think, oh, and then she said, it was from all those years and putting my washing on a washboard. And I don't know if there's any truth to that, but nonetheless, that's what she said. So anyway, so thank you.
Stay tuned.
Yes, stay tuned. Thank you, gentlemen, for joining us.
Thank you very much.
Thank you.
And as they want to say, be in good health here. So thanks for joining us. We'll be back next month. And please watch on the wonderful ECTV. This is sponsored in part by CHS. Mark, thank you very much. Lisa, thank you. And it's just another series of public health education series, again, sponsored in part by CHS. We'll see you next month, everybody. Have a great month.